So we're going to talk today about frequent cannabis users, and we're going to study how they differ from more occasional users and less frequent users in terms of substances that they use, other psychoactive substances that they use, and also motives of use and other social demographics. And this is the results are based on a large survey launched from the European Union Drug Agency. So we are going to start talking about the context very shortly and about the potential substitution of more harmful substances with less harmful substances. So in this case, we try to see whether cannabis can be used for this pattern. And to analyze this, we will try to see actually what are the pattern of use between substances through an analysis of this large survey on users using a multi-level logistic regression. And we will finally discuss some implication for harm reduction and policies. So to begin with, I start showing a picture about the increase in the prevalence of very frequent users in the US. We see in the last year it has, we could say, skyrockets, but it has increased in a very important way. And this brings different reasons. You know, there is some that is related to medical use, because in the US we know it has been implementing new policies, but also perhaps other reasons. So we see that the motives for using cannabis are diverse and might include coping motives, but also therapeutic. And this can be kind of confused sometimes because certain certain coping motives could be therapeutic, for instance, when they're used to manage anxiety, pain, and other symptoms like depression. So we also know that cannabis is used as an harm reduction strategy among people who use other drugs, especially, for example, stimulants to help fall asleep afterwards. And so this will be also something we will be able to analyze with this study. And we also have seen previous literature show that the cannabis motives are often related to frequency, and that the frequency of use is also predicting problematic cannabis use or certain cannabis-related problem and disorders related to cannabis. So that's one of the goals. So in general, we see there is a global increase in the trend of in the prevalence of cannabis use disorder. We estimate that 23% of those that use cannabis may develop at some point in their life a use disorder. And this appears to be higher, this problem, among non-medical users, so those that are not using it for therapeutic reason. So we consider that understanding which are the correlates of frequent cannabis use might be useful to understand which and to target the user more at risk and to try to orient the prevention towards cannabis-related harms, but also to understand new harm reduction strategy to reduce the use of more harmful substances. So we've seen cannabis as many therapeutic potential, but very little evidence, like strong evidence with randomized clinical trials. So most of the evidence is based on observational studies. We have seen that, this evidence is only related to few conditions for which it is used, so mostly related to pain and other stuff, but other conditions. So adolescent seems to be using it more frequently, and when they use more frequently, they are more likely to endorse to use it for coping motives. So coping motives are related to frequent use in young generation. But we also have seen that coping and conformity as a motivation to use cannabis are strongly associated with the development of cannabis use problem. So we also know that cannabis users are more likely to use other substances. But we don't know really much about the concurrent influence of other substances on the motives of cannabis use and whether there is some relation between these two motives and different substances. So this is our research question. So we are trying to understand which psychoactive substances are associated with using cannabis frequently in a European context. Which socio-demographic are affecting this pattern of use, and which motives are related to higher frequency, and if there is a difference between recreational and medical motives or coping. In generally, we have studied harms related to psychoactive substances, and there are different estimations. None is perfect, but about the different potential externality of using different drugs for the person itself and for society. And we have seen that the legalization of cannabis can affect the consumption of other substances that are perhaps more harmful for society. And we have been trying to understand this just using like administrative data to see when a state legalized what happened to the other use of other substances. But on the other hand, when we look at the clinical trials that are trying to analyze how, for instance, CBD, for instance, how it could affect the use of other substances among humans, there is very little clinical trial. There is mostly preclinical. But now there is a good news. In Australia, they are launching the first study on CBD clinical trial to see if it can reduce somehow problematic cannabis use. So there is some study made from the government, but we know there is very little compared to what we need because of certain economic and technical barrier of studying plant-based substances and do clinical trial with those. Now, in terms of substitutability, we have some evidence among the two most common illicit substances, which are alcohol and tobacco. And for alcohol, there is some evidence that there might be some substitution with cannabis. So in states in the US where they decriminalize or where they legalize some sort of medical or recreational use, there has been a reduction of certain indicator of using alcohol. But also in Europe, there was a general population survey made in Sweden that showed an inverse relation between high frequency of cannabis and binge drinking, so being hazardous drinking. So there is an inverse relationship, but there is not much more that there is. For tobacco, we see that the relationship there might be some substitution or there might be no effect at all. So that's a little bit less clear. And then when we look at opioids and pain medication, we see some impact on heroin of the medical legalization of cannabis, so substitution. And for prescription opioids and pain medication, there is some good evidence of substitution as well in different types. And lately, there was also a large review, large meta-analysis that showed that actually for chronic non-cancer pain, medical cannabis is as much effective as opioids, but with less discontinuation rates. So there is actually some potential substitution even there. When we look at benzodiazepine, there is one study that showed an association of using cannabis with the reduction or the discontinuation of benzodiazepine prescription. But for other drugs like cocaine, for instance, we don't see any, there is no evidence of any effect. So neither substitution or complementarity. So moving on a methodology now. We have 34,000 cannabis users, people that have used cannabis in the last year. And among them, about 1/3, they have been using it frequently, which means more than 20 days in the last month. So we analyze this difference and we look at the socio-demographic, the area of residence, the cannabis motives and the coping motives, and the fact whether in this country was decriminalized the possession of cannabis or not, and also all the other substances that they have been using it. And we apply some backward stepwise selection procedure to select the variables to include in the regression. And for the statistical analysis, we use a random effect within countries to understand and control for the heterogeneity between these different countries. So here are the results with all the variables. So we've seen different effects. Some is positive, some is negative, but the most evident here, the most clear, is the important positive effect on being a frequent users of cannabis of the number of coping motives for which you use cannabis. So here we have 4 coping motives. I will explain which are the one that we consider. But this is definitely the most the strongest impact on the probability of being frequent users. But we see also a positive impact on socio-demographic. For instance, we see, this is not probably surprising, that female are less likely to being frequent user compared to male. We see also some negative association with the university degree on being a frequent cannabis users. We see, and also to be a student and a student or a working student is also like negative associated, which might be surprising, but actually is not. And then we see some positive effect instead of being self-employed and to be older and to have older age. Now we look at specifically the motives for cannabis use, and especially the coping motives. So here you see there are 4 coping motives that they could be selected from the respondent, which is to reduce stress or relax, to improve sleep, to treat depression and anxiety, or to reduce pain and inflammation. So here we see that the effect is quite strong when we see when they include more coping motives, there is a stronger and likely to be frequent users. And then when we look at the other motivation, like also we see performance enhancement as also a very strong, a quite strong effect on being a frequent users, and which is more strong than fun and leisure. So that's probably because to have a performance is more regular, and fun is maybe more occasional, but we'll see later. And curiosity instead has a negative effect. When we look at the coping motives in terms of predictive margins, we see that to have used cannabis, to use cannabis for 4 coping reasons, for all the 4 that I've mentioned before, give you a 53% likelihood to be a frequent cannabis user. So that's quite an impact, like unrelated to all the rest of the variables, of course. Here we look at the other substances that are used from these users and the criminalization. So we see that for stimulants, there is actually a sort of complementarity, let's say. So there are positive association. We see, especially for cocaine, ecstasy and MDMA as well, and amphetamine. And then instead we see that for heroin and benzodiazepine, so generally depressant or hypnotics, we see actually a negative association with being a frequent cannabis user. So that's an evidence of substitution. And then when you look at hallucinogens like LSD or mushrooms, psilocybin, that's also a positive association. So they are more complementary. And finally, very interestingly, the most common psychoactive substance used worldwide, alcohol, has a negative effect, which is also quite significant and strong with being a frequent cannabis user. So that's clear evidence of substitution. And the tobacco, on the other hand, there is like a complementarity, which is also related probably for the way the Europeans are using cannabis, which is with tobacco. And then finally, we also see that criminalization of possession has a negative association with being a frequent users. So here, a bit of all the results we found, like more the summary. So as I mentioned before, tobacco, mushroom, so stimulants and hallucinogen have a positive association, and the different motivation of use, like get high, performance enhancement, and coping motives are positive. Being male is positive. Older, being self-employed, and living in a country where cannabis is decriminalized has also a positive association with frequent use, and is negative for have achieved a higher education, being a student, using cannabis for curiosity, or using alcohol, heroin, and benzodiazepine. So the discussion here, we see older users are more likely to use cannabis frequently. So we might imagine this is related to the fact that older age is associated with poorer health outcomes. People that are self-employed compared to people that are employed for someone, let's say, are more likely to use cannabis frequently, and this might be also related to the lower risk of losing their job, for instance, in case where there is workplace checking, or in places where it's hard to use it without being noticed by your colleague. Then we see that the students are less frequent, are less likely to be frequent users, because perhaps they might be related to lower income, purchasing power, or other issue like that. And then we see that to be using it for productivity is as much of a stronger effect than using it for fun, which is probably related to the need of using it every day, or at least when you work or when you have to be productive, while you don't need to, have fun every day, let's say. So, and then we see that the more coping motives, so we could say also the more comorbidities in some sense, for which cannabis is used, the more likely to be a frequent users. But besides that, most of these users of the frequent user use it at least for free coping coping reasons. We only see about 1 out of 50 of these therapeutic users that are enrolled in a medical cannabis program. So there is very little access to this, and we will see why this is happening now. So frequent use is also strongly and dose-dependently associating with reporting coping motives. And we see that this impact, probably the most interesting results, is the fact that the cannabis users that are frequent are less likely to use heroin, alcohol, and benzodiazepine. But what we understand is this difference in magnitude between alcohol, and we need to understand alcohol and benzodiazepine, which might be surprising if we consider that these people are using it, these individuals are using it sort of for certain therapeutic use. But we need to also consider that the decision that are taking from physician to prescribe a benzodiazepine versus cannabis, for instance, for conditions like anxiety or insomnia, which both have evidence of efficacy, some evidence, there is not driven only from the efficacy, but also from the side effects and also from institutional reasons like reimbursement policy, but also the legal protection in the workplace for drug checking, but also of drug driving laws. And this is something very considerable because, the ability to drive is affecting the quality of life in general. And we see that the drug driving law are a major barrier to access to become a cannabis patient in the countries where there is a repressional approach towards them. Indeed, we see that there is a medical defense for driving under the influence of psychoactive substance that has therapeutic application if they are prescribed and taken in accordance with prescription in general. But this is not the case. This is the case for benzodiazepine, for opiates, but it's not the case often. Very rarely is the case for cannabis. So there is very rarely a medical cannabis exception. So actually, medical cannabis patients are more treated like alcohol drinkers rather than sick individuals in terms of law when they're driving. And actually, there is a trend in identify the impairment only based on the THC level that are present in your biological matrix, which could be blood. But now, recently, also saliva, for instance, in France has been implemented because it's less invasive. But actually, these tests are really failing in discriminating between those that are impaired and those that are not. So especially this for frequent users because of the tolerance they build over time, which is common to other medication. So the first study that actually have been only looking at the impairment on medical cannabis patients have found no impairment at all. So this is because actually there is some improvement in clinical symptoms that offset maybe any detrimental cognitive impact of cannabis. And so even though driving under the influence of benzodiazepine has been considered more risky, is considered in terms of danger compared to using medical cannabis, they are treated very differently. And so the substitution that we see now, which is kind of small, it might be much larger if the legal protection might be comparable. And to conclude now, if we see that a substance acts as a substitute for cannabis and imbues more harms, we could imagine this to be studied for the treatment, cannabis to be studied for the treatment of drug use disorder for this substance that has higher expected harms. Or also to use cannabis to lower or stop the use of alternative medication that has strong side effect and low efficacy. So this is, for instance, this is the ranking of drugs according to NAT. It's all stat. So in this case, we see alcohol and heroin where we see some substitution. They have higher expected harms compared to cannabis. So cannabis could be considered as a harm reduction way for people that use these substances. And on the other hand, benzodiazepine, the expected harms is lower compared to cannabis if we consider both the harm to themselves and to society. But if we consider only the harm to the users, is actually more harmful than cannabis. So maybe in this study they didn't consider the harm to society that has been found related to drug road risk with benzos. So yeah. So to conclude here, the implication for harms reduction is that this information can help to build this new concept of drug social clubs, where people can have experience in polydrug use practices and environment with information about how better combine these different substances and to find the optimal dosages to have the maximum benefits. And so quality research could be targeted for users of more harmful drugs to understand the acceptability of cannabis as a substitute. And it could be investigating the motivation behind polydrug use of cannabis and other drugs. So some limitation here, but we can see it later. Thank you. Thanks for the attention.